It's my pleasure and honor to introduce you to the MITRE Corporation's Early Career Research Program. For the past 3 years, MITRE has invested $1 million each year to develop science, technology, engineering, and mathematics leadership. Created within MITRE's Innovation Program, the Early Career Research Program helps develop critical leadership skills, including how to perform research, how to manage a research project, and how to communicate results effectively. The Early Career Research Program is highly selective, and each participant pursues a particular research challenge under the careful guidance of an experienced research mentor, often simultaneously pursuing an advanced degree. Many participants work half-time on the direct program, accelerating transition of their research to MITRE sponsors. Now in its third year, the program has contributed to the development of 20 extraordinary individuals. Prior participants have had their work externally recognized, for example, as best papers at conferences, and even acquiring direct funding from the government. So, please lean forward and enjoy meeting one of MITRE's early career researchers.
While we wait for those slides to get up, I want to take this opportunity to thank everyone who's helped me along the way with this program and for being selected in the first place. This is a really great investment in our young employees, and I know that all of us are really grateful for that investment, and specifically Rick Sciambi, who acted as my mentor in helping me to navigate the program, which was really quite new to me, and I guess new to all of us as a new program. So thanks to everyone. All right. As Mike said, I'm Ellen Sweeney. I'm with the Center for Transforming Health. I am a public health analyst, and my research project focused on the evaluation of innovative healthcare delivery models with a specific focus on my primary customer, the Centers for Medicare and Medicaid Services, or CMS. I want you to imagine for a moment that you're a division director at CMS. You're responsible for implementing one of the first pay-for-performance programs the federal government has ever done. It's a very high-profile program that's been authorized by recent legislation. It's been up and running about a year, and you get a call from these gentlemen on the Senate committee that's devoted to healthcare issues, and they'd like a status report. You come down to Washington, and they ask you a few simple questions. How's the program doing? Are we achieving the outcomes that we outlined in the legislation? Are there unintended consequences that we should be aware of? And you don't know. You don't know. So why don't you know? Was the question unexpected? Were you caught off guard? Well, you shouldn't have been. The GAO has been issuing a series of reports indicating that there is a really urgent need for CMS to monitor and to pay attention to these new quality and payment initiatives, both to ensure that we're having the impact that we intend, but also to look for unintended consequences, make sure there aren't disproportionate impacts that are actually harmful that can come as a result of these changes. So you should have seen the question coming. So maybe you just don't have the data. The program's relatively new. Maybe those processes are getting into place. Well, again, CMS is sitting on piles and piles of data in the form of claims and administrative data related to beneficiaries and to providers. It may not be in the format you would have liked if you were designing your own research project, but an analyst who knows how to make the numbers talk could work with this data to give you some more information about what's happening there. So why don't you have a good answer? To explain how this could be the case, I want to give you a little bit more context for the agency. In 1965, Medicare and Medicaid were signed into law by President Johnson. It was an expansion of the Social Security Act. It started a new entitlement program, and it was run by the Social Security Administration for the first 12 years. In 1977, the program had grown to the extent that they put it into a standalone agency, then known as HCFA, the Healthcare Financing Administration, now known as CMS. The primary mission of that agency for over 40 years was to administer that entitled program as set out in federal law. So CMS was essentially acting as a giant insurance company, the biggest one in the United States of America. But unlike other insurers, did not have as many tools at their disposal to help to manage their benefits and their healthcare costs because of the regulations that they were required to follow. So for a long time, this wasn't a big deal. Healthcare costs didn't used to be nearly so expensive. And medical science was just less complex. Life expectancy was shorter. People weren't living as long and incurring costs. And they weren't living long enough to develop a lot of the expensive chronic conditions that are really draining our resources today. But as all of those factors changed and there was a population demographic shift with the baby boomers aging, healthcare costs have spiraled out of control. They're rapidly outstripping inflation to the point where they're on track to exceed 25% of our GDP in just the next 12 years or so. Even if we were to slash everything by 15%, just cut the entitlements by 15%, it's only going to buy us about 5 years. The system as it's designed is not sustainable. The only option to getting it under control is to bend that cost curve, and the only way to do that is a fundamental reform of the way that we deliver and pay for healthcare. Now, you might argue that this investment in healthcare is worth it. It's an investment in the American people, and if we're achieving great outcomes for this money, maybe that's something that's worth spending money on. The problem is that if you look at the United States' outcomes compared to what we're investing, we are a clear outlier. We have one of the most expensive healthcare systems in the world and some of the worst health outcomes of any developed countries. We're just not getting the return on investment we would expect relative to the experience of other developed countries. So it was in response to this looming crisis that President Obama signed into law the Affordable Care Act. Now, Obamacare is best known for the creation of the health insurance exchanges, but it's really about much more than that, and it represented a fundamental mission shift for CMS from an agency that primarily administered an entitlement program to an agency that was expected to take a more active stewardship, not only of the government's investment in healthcare through these programs, but also being a pioneer for reform of the United States healthcare system as a whole. So a few of the key types of programs that were included in the Affordable Care Act, there were a number of quality and pay-for-performance programs intended to address that poor outcomes component. There were a lot of payment and financial incentive reform programs that are intended to incentivize efficiency, reduce utilization that's unnecessary, and generally rein in costs. And one of the big changes was the creation of the Innovation Center, which is known as CMMI. Now this was essentially a new branch of the agency that was created specifically to start tinkering with the program, to start testing out new ideas that might bring in our healthcare costs, deliver care in a more efficient way that has better outcomes. It granted CMS the license to innovate in a way that they did not have previously. So there's just one problem with this. Success in one endeavor does not guarantee success in a tangentially related endeavor. CMS spent decades building the infrastructure to administer that entitlement program. They did not have the staff and the resources to necessarily address this change in their mission shift. Their staff and resources were focused on paying claims, and now they needed to move over to really a very different way of thinking about how they were engaging with the healthcare system and healthcare management. And they were expected to report back on their results, on how they were doing and what it meant for the US healthcare system as a whole. So the challenge I was addressing with my research project, we know there's this big room for improvement in quality and safety. We know we need to improve efficiency and that our costs are unsustainable. So Congress has granted this tremendous opportunity for CMS to be the leader in that effort. But how do we know what's working? We need to know what works so that we know what direction to take. We also need to be able to justify the burden to providers. If we're asking them to change the way that they operate, we need to have a good evidence and a good reason for doing so. And there's also the risk of unintended consequences here. There can be unintended impacts of these programs, groups that are disproportionately affected in ways that we don't want, and it's important to know that as well as what's working as a whole. So the question that I asked myself when I started this research project was, how can we, as an FFRDC, help CMS to quickly adapt to their changing mission? I identified monitoring and evaluation as a critical capacity that was needed right away, in which CMS didn't have quite enough strength in. M&E is highly technical when it's done right. It's a method of modeling and analyzing program data to identify trends and separate signal from noise, start to assess the cause of the trends that you are seeing and their significance. CMS hires contractors to do this work currently, but due to a lack of experience in the field, sometimes struggle with giving the contractors the direction they need in order to get back the results that they're looking for. So a few key components of M&E that I want to go through. Formative evaluation has to do with what should we do. It's identifying the problem, then starting to develop what are the outcomes we are trying to achieve. What are the mechanisms that we are going to use to affect those outcomes? And then what activities are we going to undertake to move those levers and ultimately influence our outcomes? Monitoring is something that you do during the program. It says, how did we execute? Is this how we intended to operationalize it? So for example, if in formative evaluation we identified a problem as not enough people have health insurance, we would like to increase the number of people with health insurance. In monitoring, we might ask the question, if one of our activities is to set up a website in which people can access insurance, in monitoring we might say, okay, can people access the website? How many people are accessing the website? How many people are signing up for insurance? And then summative evaluation looks at the ultimate impact of the program. So how many people achieved coverage as a result of those activities that we undertook? So a result of the formative evaluation is a logic model, and this forms your blueprint for the program. It shows you exactly what you need to measure, but beyond that, it's just really important from a program perspective. It can be easy to get caught up in activities and lose sight of the ultimate goals that you're trying to get to, so this helps to improve focus, and also just to prevent mission creep. Like sometimes things get tacked on, they're not really critical to achieving that ultimate goal. It helps a program to focus its resources on what matters and moving those levers and getting the outcomes that we're trying to get to. So my research objective was to strengthen CMS's capacity for monitoring and evaluation, to improve the usability and the timeliness of the information, the consistency across programs, so that decision makers, when they're looking at information across programs, can have some sense of how they are relative to each other, and to reduce the level of effort and expertise of the staff who are implementing these monitoring evaluation programs or who are overseeing the contractors who are doing them. So the intended impact, of course, now is that CMS and Congress would have a clearer understanding of the strengths and the weaknesses of the many new initiatives that are underway, as well as the future innovations that are happening with the Innovation Center. Well, it turned out I was pretty on point when I identified monitoring and evaluation as a critical capacity. As it happened, my research project aligned perfectly with a need at the Innovation Center to help them with the Healthcare Innovation Awards second round of grants. So how often do we get the opportunity to immediately take our research and apply it directly to customer problems? So I jumped into this project and helped to develop a repeatable framework which the team of MITRE analysts used to compare to evaluate all of these proposals, so that we were focusing in on the common elements, the critical elements that needed to be compared across them, but also it gave us enough flexibility that we could add in additional elements as it was needed for proposals that had unique aspects to them. So using this repeatable framework, the MITRE team was able to analyze well over 200 proposals in just 6 months. Before we had completed this analysis, CMS had identified roughly 100 or so proposals that they were interested in, they thought were promising, worth about $900 million in grant funding overall. When they combined in the results of the MITRE analysis, they narrowed that down to the 40 proposals they felt they had the strongest confidence in would actually achieve the return on investment that they stated for roughly $400 million in grant funding. So in other words, using the MITRE analysis, they were able to identify $500 million they were going to invest in these programs that they actually now think maybe aren't confident enough will have that return on investment, and they will not put the government's resources there. So in conclusion, the federal government is really remarking on a tremendous transformation and mission shift for CMS and how we incentivize high quality and efficient health care. I've spoken a lot about the economics of the situation and the technical capacity for CMS to achieve those goals, but I think it's really critical that we not lose sight of the human aspect here. Every data point, every claim form represents a significant moment in a human being's life. When I think about these care coordination programs, I think about my grandfather who had a cancer in his chest grow to the size of a hockey puck because the lab results got lost between the lab and his office and his provider's office. And it was no one's job to make sure they got there. It was no one was incentivized to ensure they got there and trigger a phone call to my grandfather. When I think about the exchanges, I think about my unemployed friend who went without her medications for months because she couldn't afford them and she couldn't access the exchange to get the insurance coverage that she needed. These programs touch millions of lives, and they have impacts not only on health, but on happiness and on quality of life. In the defense and the intelligence sectors, it's taken as a given that we should always be actively acquiring and mining and interpreting data in order to protect lives and livelihoods. So too should CMS be actively leveraging the data at their disposal to improve lives and livelihoods. And our job as an FFRDC is to help them to have the capacity to accomplish that, because it impacts not only our debt and our future and our national security, but also the lives of the people that we love today. Thank you for your time, and at this point I can take questions.
So at the end you mentioned, I think it was like $500 million in potential savings. Do you know, are those like decisions that have already been made? Are they considering them because of your framework, or what's the outcome of the issues that you've raised because of the research you've done?
So the program had a pot of roughly $1 billion of funding to distribute, and they were all set to distribute about $900 million of it. But when they looked at kind of their confidence in these models based on the MITRE analysis and whether they would actually achieve their return on investment, they said, you know, that other $500 million actually probably isn't a good investment, so let's hang on to it and we can invest it elsewhere in something that we have more confidence in. So that's that part of it. The other part of it is that the models themselves are intended to improve, to change care delivery models. I apologize, I probably should have gone into this more. But the program allows applicants, so providers or public health entities, or really any kind of entity, to submit a proposal for a way to deliver health care that would improve outcomes and reduce unnecessary utilization, but which is not currently possible due to the way that CMS payment policies are structured. So in addition to proposing their intervention, they're also proposing the payment model that they believe would be sustainable in an ongoing manner, and that's something that CMS would consider incorporating into their policy. So there's a lot of, so we were modeling out essentially the cost savings that we would anticipate these different interventions and the alternative payment models to achieve. So that $500 million is just the now direct funding that didn't go into those projects, but then all of these innovations may be coming up with hundreds of millions of dollars in savings. That's the hope anyway. I mean, there are 3-year grant cycles, so we'll have a lot more information as that progresses.
How are you planning to use the evaluation with vague measures such as improved health?
Well, so you don't use vague measures. You use very specific measures. So the logic model, which I'll flip back to quickly if I can do that. Well, just imagine in your head that logic model that I showed you. The logic model is the way that you take a vague idea that's, for example, in legislation, is something we'll say to improve the health of patients, and you start to get much more specific about what you're looking for. So in the example of the end-stage renal disease quality incentive program, which is a model that I helped develop with MITRE as we helped the federal government to stand up that first pay-for-performance program, it does say things like improved outcomes and improved access to care, and then you would drill down into that and say, what measures are we going to use to actually assess whether that's the case? The good thing about a logic model is it's also supposed to incorporate the intervening factors. So instead of just looking at those trends and saying, oh great, my program caused this, you're making sure that you're actually measuring every step along the way, and those other intervening factors, for example, socioeconomic status or education level, that could also be causing those outcomes, and accounting for them. So, as I said, M&E is highly technical, and it really is about separating signal from noise and getting specific.